Welcome back, everyone. I hope you've had a good week. It's nice to see so many faces. A couple housekeeping issues before we start today. First, the slide went off. I always use Jeff now. There was a slide up here introducing the Center for Bioethics Grand Rounds that will be co-sponsored. Thank you very much. That will be co-sponsored by the School of Public Health. And we wanted to get this out there and in your calendars if you're interested. It's understanding the health and well-being of sexual and gender diverse populations. Findings from a new National Academy of Sciences report. The date is October 29th around lunchtime. So this will be of great interest to many of you, I know. So we just wanted to get it out there and into your calendars if interested. Details for registration in the Zoom will be found in other materials that are coming up through the school as well as through the Center for Bioethics. So thank you. The other thing I wanted to announce before we get started here is that next week, we will have another obesity-related conversation, and that will be with one of our newest assistant professors here in the division, Dr. Katie Arlinghouse, and her topic will be Nobody is an Average, Next Steps for Addressing Pediatric Obesity in Community Settings. So we're super excited about that. And then lastly, a super warm welcome to the alumni that may be present among us today. We have reached out specifically to you, and we hope that you come back to our EPI seminars each week. So without any more conversation from me, let me introduce our speaker today, who I'm super excited is here. And in fact, before we opened the waiting room to have you join, we were having a lot of good laughs, remembering some old times. Sean Phelan is a graduate of our program, and I would tell you which year he finished, but one of us may have been on his dissertation defense committee, and one of us would feel really old if we told you what year he finished. So I'm going to skip that year, but I will tell you that he did earn his PhD from this program, and it wasn't that many years ago. But it's so good to have him back. So welcome back, Sean. Sean is an associate professor of health services research and the section head of the social and behavioral sciences the section head of social and behavioral sciences in the Division of Healthcare Delivery Research at the Mayo Clinic. Sean's research program is focused on understanding the implications of stereotyping, prejudice, and discrimination in regard to health and medical care for members of stigmatized, marginalized, and minority groups. He is especially interested in unconscious cognitive processes and how they may influence the behavior of healthcare providers, including communication with patients and clinical decision-making. The ultimate goal of Sean's research is to develop interventions to help healthcare providers reduce the impact of unconscious bias and provide patient-centered, compassionate care. He is also investigating ways to provide patients with strategies for attaining high-quality care and reducing the impact of discrimination in healthcare. Sean's research will help improve the way that healthcare providers communicate with their patients and provide a healthcare environment that feels welcoming and safe. His research is aimed at reducing disparities in quality of patient care and treatment decision-making. And one of the reasons that we thought it was important for Sean to come back and visit with us today is that we take stigma and reducing stigma very seriously in our division and in our school. So today, Sean will be speaking to us about weight bias in healthcare, evidence, impact, and solutions, importantly solutions. So again, welcome back, Sean. It's good to have you.
Yeah, thank you. It's good to be back. Also a little nerve-wracking to be back. And somebody pointed out, they said, good luck redefending your dissertation. So doesn't quite feel like that, but something similar to that. But it's so great to see so many names and faces of people that I was here with or studied with. So I'll get into my presentation here. All right, hopefully everybody can see the title slide. Um, yeah, so I'm
Oh, just a second, Sean. You ended up sharing your presenter view. I think you want to share the other window.
does this view work? Is this okay?
This is fine if you. Yep, this is fine.
Okay. Yeah, I don't want to mess with it too much because I don't
Okay.
know. Yeah, so what I'm going to be presenting is some of the research on body size bias in healthcare that I've been working on over the last 5 or so years. Continue to be working on. This is I sort of wear several different hats at Mayo Clinic, especially as the section head for social and behavioral sciences. But as far as my personal research program, personal mission, it's really focused on stigma broadly. Stigma, I do work on stigma associated with minority sexual orientation, gender identity, disability, certainly racial bias and things like that. But the bulk of my work has been focused on people with obesity. So let's see if I can get this to work. So starting with some evidence. First, just a definition of stigma. The quote from Irving Goffman in his 1963 book that people usually quote is that stigma is an attribute that's deeply discrediting, that reduces the bearer from a whole and usual person to a tainted, discounted one. There's another. The second quote is one that I really like because I think that it touches on the obesity stigma experience well, because it's such a visible and salient identity, especially in a healthcare setting. That stigma is a trait that can obtrude itself upon attention and turn those of us whom he meets away from him, breaking the claim that his other attributes have on us. So what is stigma? We know that societies devalue people who have certain characteristics. That stigma represents the standards that society applies to define who is normal from who is deviant. And that from that, members of stigmatized groups often experience bias and discrimination. Stigma has its roots in several different fields. There's certainly an evolutionary component to stigma that we sort of evolved to reject things that might be considered dangerous, people in our community who might be considered less desirable. Those kinds of distinctions, those heuristics that have been built over, a long time are less useful now, but they're the echoes of them still affect how we think about each other and treat each other. And stigma serves a lot of different purposes. I like to think of stigma as both resulting from the dual system of cognitive processing and then also kind of reinforcing that dual system. I'm sure everybody's familiar with unconscious versus explicit bias or implicit and explicit bias. But we have two thinking systems. One, system 2 is explicit, it's effortful, it's reflective, it's what we are using when we say we're thinking about something. But the majority of our cognitive processing happens implicitly. It's very efficient, it's reflexive, it happens extremely quickly, and it serves a few different purposes. It serves cognitive efficiency. It would be disabling to have to reevaluate or evaluate every piece of information we receive, right? So we build these heuristics, these rules in our mind that sort of make information available to us immediately. It serves a sense of belonging, right? When we adopt the assumptions, the implicit sort of group attitudes of a group, that's part of the socialization into a group. It certainly, especially historically, has been part of protection from perceived threats. We don't have to, evaluate and think about the possible risk of a threat that information is immediately available to us. We have that stress response and we can act on it without having to fully process it. And finally, it serves the belief in a just world, which is an interesting concept. We tend to want to believe in a just world, even unconsciously want to believe that the world is just. And so stigma or stereotypes, prejudice about a group can serve that need because it justifies historical and current poor treatment of that group. And so that's what I'm kind of talking about in this next slide. This is the extremely simple model of obesity and disease that is sort of the cause of a lot of these problems. It's a very simple causal model. Nutrition and exercise, the behavior leads to obesity, which leads to disease. And the natural, takeaway from that is if we can get people to make better decisions, they would not be obese and would not have these chronic diseases. There's two reasons that model, two theories that describe why that model sort of leads to stigma and discrimination. One is attribution theory, that we're more likely to help a person whose distress originates in an uncontrollable cause rather than a controllable cause. So in that way, this simple causal explanation serves cognitive efficiency. It helps us make sense of the world. The flip side of that is justification suppression theory, and that has to do with the just world theory. Attributions to controllable causes justifies pre-existing prejudice, and that serves that need to believe in a just world. And of course, there are emanating from this or resulting from this a list of explicit stereotypes and prejudice that perpetuate and justify separation and discrimination. Stereotypes and beliefs that are not uncommon, even among healthcare providers and very educated and egalitarian people, right? Beliefs that fat people are lazy, that fat people don't understand nutrition, that fat people strain the healthcare system and require more resources than thin people. Obesity is the result of bad decisions, low self-respect, and no willpower. I'm going to just take a break here to just touch on language real quick. There's a lot of disagreement within the different corners of obesity stigma research around what to call people with obesity. Everyone mostly agrees that using obese as an adjective is pejorative, is not the best way to call people. So I try to avoid obese people, like it says there. The obesity researchers tend to advocate for person-first language, so saying people with obesity. I use that language a lot, especially when publishing in those journals. It can be a mouthful, but it's a way of signifying that you mean to be respectful. There's a whole other part of this research done by health at every size advocates, eating disorder advocates who prefer not to use the diagnosis obesity and actually really reject person-first language because it implies that obesity is a disease, which is something that a lot of them reject. So they'll use words like higher weight, larger size body, or fat. And oftentimes people do use the word fat, not to be pejorative, but because it's their preferred term. So I move in and out and use lots of different terms. It's the language is important, but it's also the condition that's stigmatized. And so eventually whatever word you use will become pejorative. But oftentimes if I say obese people, it's because that was the wording and the measure in the study I was doing. But so forgive me if I use a term or a word that's particularly offensive to anybody here. It's certainly not intended that way. And then what's the next point there? That stereotype consistent information increases prejudice. So Paula Broku, a colleague of mine, did a study showing that public opinion on a proposal to deny fertility treatment to women with obesity found that people supported it more when it was accompanied by stereotype consistent images, images of people with obesity acting in stereotype consistent ways. I'm going to move here. So this is the more complex model that one of the models sort of that I use to describe and plan research. Here, there's still this sort of triangle of bidirectional cause, right? Nutrition, exercise causes obesity. Obesity in turn contributes to, worse exercise, right? That these things, independent of obesity, affect chronic disease. They affect obesity. It's this triangle here that I think we're familiar with. But there's a few things that I think are more acceptably added in here, that there's genetic predisposition and environmental obesogens that contribute to obesity. And then these things that are in red is sort of where I try to target my work, right? That obesity contributes to stigma. Stigma itself can affect how we feel about ourselves and thus how we eat, how we exercise, whether we feel comfortable exercising, where we might be visible. That stigma causes a stress response, which also leads to increased adiposity and chronic disease. And that stigma affects healthcare. It affects provider bias, which can in turn affect quality of care, stress, and disease outcomes. Let's see, where's my... So I'm gonna kind of just roll into this first study. So this one is from a few years ago, really just kind of establishing the prevalence, the seriousness of the problem of weight stigma in healthcare settings. Sorry, I was just reading the chat. So medical student changes was a prospective cohort study of medical students. We sampled 50 schools. We ended up dropping one of them because it ended up being a military school, and students didn't finish in the 4 years that we sort of had for the study. It would have been wouldn't been able within our study protocol to collect data from them in the same way as the other. So we ended up with 49 schools. The schools were selected. The number was proportional to the size of 12 strata by public and private and region of the country. We contacted incoming students via email in their first semester. We did that a couple ways. We embedded a question asking for their email addresses in the AAMC matriculation questionnaire. And then we used a snowball sampling strategy where people could contact their fellow first-year students and give them information about the study. Through that, we were able to get 4,732 responses, which was 81% of the email addresses we were able to ascertain, and 56% of the total incoming classes at those 49 schools. The sample distributions for race and sex were similar to all students at participating schools. And then we repeated the survey in the 4th year of medical school, and then the grant was renewed in the first, second, and third year of their residencies. For measures of bias, we had two different measures of weight bias. 100% of the sample completed explicit measures. So they completed Christian Crandall's measure, the anti-fat attitudes test, and a series of feeling thermometers, which is what I'll present here. Feeling thermometers are a very quick way to grab explicit warmth or favorability towards a group. You present a picture of a thermometer or several pictures of thermometers with groups, next to them. And it's 0 to 100. It's anchored at the bottom, very cold or unfavorable, very warm or favorable. And people are just asked to move a slider to the position that represents their feelings towards that group. To measure implicit weight bias, we use the implicit associations test. With 50% of the sample, half were randomized to take one about sexual orientation, and half took the obesity IAT. A little bit about the IAT, because there's always a lot of back and forth about its value and validity. Self-report measures do outperform the IAT when measuring decisions. So for example, in a meta-analysis of 61 studies, the political preference could be predicted the correlation was 0.67 for just asking somebody versus 0.41 but with the IAT kind of identified preference. However, predictive validity is not affected by social desirability like it is with explicit measures. It's most predictive of nonverbal behaviors and behaviors under cognitive load, which describe healthcare scenarios quite a bit. Decision-making with limited time while trying to hold a lot of information in your head. And that implicit bias also influences explicit processing through confirmation bias. We look for and attain to and later recall information that's most consistent with our initial implicit and affective flash or implicit expectations of something. So this is the results of that feeling thermometer among first year medical students across the country. What this is, the zero line represents everybody's rating of white people, which is I'm just using as an anchor. And you can see here, so for some reason my error bars disappeared, but if you can imagine tiny, tiny little error bars sticking like a centimeter above and below each blue square, that's about what they looked like. And you can see here that on average, incoming medical students rated Hispanics and African Americans about 2 points less favorably than whites. Gay men and lesbians between 4 and 5 points less favorable than whites. Muslims about 7, poor people and transgender 8 points less favorable. And the outlier there was obese people were rated on average about 16 points less favorable than whites. So you could see they stand out as a bit of an outlier as far as explicit warmth. There was one that would be up there in the corner a little bit higher than obese people, and that's injection drug users, which is also a really interesting stigmatized group. But that's for another time, another discussion. Let's see. So here is how these explicit attitudes change over the 4 times we collected the data. So this is a favorability rating, so higher is better. So despite sort of what we just saw, the sort of negative outlier, first year medical students was the most favorable people were towards people with obesity, about 69 points on average out of 100. By the time they graduated, that had dropped significantly to 64.8. Held a little stable through their first 2 years of residency, and then by their 3rd year of residency, where they're sort of getting ready to go into practice or into fellowship or whatever might be next, it had climbed quite a bit, but never quite reached that pre-medical school, beginning of medical school level of favorability. And I'll come back to that a little bit later, actually. These are some basic kind of graphic results of the implicit bias test. This is really expected. About 74% of students identified having moderate or severe anti-fat bias, according to the cut points that are commonly used with the IAT. In here is the slight bias or no bias, and then over here is the minority who actually depicted some favorability, implicit favorability towards fat, larger body sizes. And how that did over time, we measured that 3 times. People started up here in their first year between moderate and severe. So severe implicit bias is considered 0.6 and above. It's a different score. I don't think it's important to get into right now. But what's important is that by their end of medical school, their implicit bias had improved. They dropped below moderate into the slight bias category, and that remained relatively stable through the first 3 years of their residency. So there's some good news there. So in this next part for changes, I'm going to be talking about what predicted attitude change in medical school. So this was a different paper. For the MS4, the 4th year survey, we had 1,795 students completed the who completed the FACT and IAT completed this 4th year measure, which was about 80% retention, which was great. We measured school level variables, including the formal and informal curriculum, the hours of training related to health disparities, interpersonal skill building, dealing with difficult patients. We measured contact, amount, and favorability of interaction with medical students, faculty, patients with obesity. And we measured role modeling, the average response to items measuring faculty discrimination towards patients with obesity and faculty derogatory comments and jokes about people with obesity. And these are those 2 final multivariate models. These are models, linear models predicting 4th year implicit and explicit bias adjusted for baseline. And I want to highlight the significant findings here in yellow. So a significant finding of greater bias, so worse bias, was the number of hours of training and dealing with difficult patients, which was interesting, a little bit of an unusual or unexpected finding. What that reminds me of, or my hypothesis around that, is the process of othering, making people feel that teaching that there are patients that need to be treated differently because they're difficult patients can sort of, I don't know, enhance the feeling that they're other, that they're different. And oftentimes, because patients with obesity are considered to be less adherent, considered to be in some studies a waste of time, they're sort of often considered to be difficult patients by a lot of providers. The favorability of interaction with patients with obesity improved implicit and explicit bias over the course of medical school. And this role modeling measure that faculty, residents discriminate against, make negative comments about patients with obesity, was increased bias over the course of medical school. So role modeling, and I'm gonna, towards the end here, I'll get back to talking about role modeling, but role modeling seemed to be really important in that. So shifting to impact, the primary ways that bias affects the healthcare encounter, it affects patients, individuals in a lot of ways, but the way it affects the healthcare encounter is through communication and through clinical decision-making. The patients, and this is from the literature, patients with obesity who report feeling stigmatized or judged are more likely to delay cancer screenings and other routine preventative care. They feel less motivated to change behavior. They're more likely to doctor shop and not have a single trusted primary care provider. They're less satisfied with their care, and they may experience a stereotype threat response, where if you feel threatened, if you feel bad, if you feel like you're being treated in a stereotypical way in a certain setting, it's a natural reaction to avoid that setting. And so that brings me to this study. This was a really recent study. It was just published. We used the data from the LHS Net network of care organizations. So we sent out a one-time only survey. There were some limitations to using this LHS Net data. So one-time only paper invitations to 20,000 people from 5 clinic sites across the US whose medical records indicated that they had overweight or obesity. We received survey responses from 2,380, or about 14% of them, so a low response rate. We invited and received responses from equal proportions with BMI corresponding to the overweight category, the obesity class 1, the obesity class 2, and the obesity class 3 category. We use previously validated measures of perceived stigmatizing situations in healthcare, perceived respect from doctors, and patient-centered communications. The outcomes that we looked at were these 2 questions. In the last 12 months, have you switched doctors or tried to find a new primary care doctor? And then the second one's actually several questions, but it was yes to any compared to no. In the last 12 months, compared to no to all. Have you delayed or avoided getting healthcare because you gained weight, were told to lose weight, thought you would be weighed, thought you would discuss weight, thought you would be asked to undress, thought you could get rid of the problem by losing weight? We did multivariable modeling, and all of these associations adjusted for potential confounders were significant. But then we kind of went on to map these associations to a set of indirect effects models. And again, this is cross-sectional data, so these are indirect effects models. I may drop into the language of mediation, but I don't mean it as causal mediation. These are a priori models that we had that we fit the data to. And in both of these models, for both outcomes, doctor shopping and delayed care, BMI alone significantly predicted perceived respect. It significantly predicted doctor shopping. Once you accounted for the indirect effect of stigmatizing experiences and lower patient-centered communication on both perceived respect and doctor shopping, the association between BMI and perceived respect drops away, or the association between BMI and doctor shopping drops away. So these two effects are both, fully mediated, is what might say. You could argue that that's the wrong term, but they're accounted for by these indirect effects in this model. That stigmatizing situations and lower communication causes, I'm doing air quotes around causes, lower perceived respect and more likely to be doctor shopping. And it's the same situation over here for delayed care, except the association between BMI and delayed care remains significant, but still the pathway between BMI, stigmatizing experiences, patient-centered communication, and perceived respect delayed care was significant, adjusting for each other, all of the pathways in the model. Some of the other implications of weight bias from some of the literature for communication, there's really extensive evidence that bias influences interpersonal behavior. That's racial bias, weight bias, disability bias, all kinds of cognitive biases. For obese patients, there's studies that have found they experience less rapport and less relationship building communication, less patient-centered communication, that they spend less time on education. There's a study I won't get into here that we published a year ago showing that among oncology patients, providers spend less time overall treating patients with obesity in oncology appointments. And also that high bias providers are less likely to be recommended to family or friends. That's some work that I'll talk about in a second. Communicate less patient-centeredly, less warmly, and that results in lower patient satisfaction. This is the result of some qualitative interviews that I did with a colleague of mine, Richard White, down in the Mayo Florida Clinic in Jacksonville. Patients with obesity reported lack of empathy from providers, feeling blamed, feeling that everything was attributed to weight. Some of the words that people used in those interviews was that they dreaded going to see the doctor, that they felt discomfort, embarrassment, and feeling exposed during encounters. And they used words that providers seemed bothered, dismissive, avoidant, that they were utilizing scare tactics or in attack mode when they were addressing obesity during their encounters. So the context study, this was a couple of years ago. This was my K Award study. We sought out to define what medical school experiences and what medical student attitudes are associated with actual behavior, less patient-centered care for a patient with obesity. So we did this at Mayo Clinic only. 111 out of 160 third and fourth year medical students over a 2-year period. Everybody completed a survey, and approximately a month later, we're then re-invited to participate in a patient care simulated scenario at our simulation center. Those encounters were videotaped and evaluated by trained coders using RIAS, evaluated coding system, to assess provider anxiety, dominance, attentiveness, friendliness, engagement, sympathy, hurry, respectfulness, and interactivity. And we also coded nonverbal behaviors and the likelihood that the coder would recommend that provider to a family member or friend. The standardized patient that they saw was one of 4 men that I hired who trained to consistently depict the same case. All 4 patients had a BMI over 30, a real BMI over 30. They weren't just playing that, but that was their body, their BMI. The students received doorway information saying what the BMI was, that the patient had osteoarthritis in their knee. The patient would describe seeking relief for knee pain and wanting to avoid long-term disability. And they had been told by a surgeon that they weren't eligible for joint replacement surgery because of their BMI. So the case was designed to make a weight loss discussion come up, and it did in each time. We had a couple of measures of kind of social context within medical school and also attitudes. So we used the role modeling measure that we had developed for changes. How often have you heard professors, residents, or attendings make negative comments, use derogatory humor about obese patients, or you yourself have witnessed discriminatory treatment of obese patient? We used a couple items from the Attitudes Towards Obese Patients scale developed by my colleague, Rebecca Poole. The perception that anti-fat attitudes are normal for doctors. My colleagues tend to have negative attitudes towards obese patients, and practitioners feel uncomfortable caring for obese patients. We also use the implicit associations test and the anti-fat attitudes test as well. Communication quality was evaluated using the Rotor Interaction Analysis System, RIAS. So that includes ratings of global affect, and I listed all those things in a previous slide, but then also the overall patient centeredness score, which is the ratio of relationship building, sort of soft utterances to purely biomedical utterances. We also used a patient-centered behavior index, including things like the provider listened carefully without interruptions, allowing sufficient time for response. The provider displayed an open, receptive, and interested posture, and there were 12 items altogether. And finally, we asked them, or the observers, the coders, were asked if they would recommend this provider to family or friends. So these are the results of those models. There was no associations with implicit attitudes among students. Only one among explicit attitudes. That explicit dislike was associated with coder being less likely to recommend that student to a family member or friend. However, the role modeling and the perceived norms among doctors is where we got the most interesting results. Negative role modeling was associated with the student being evaluated as being less friendly, having a lower score on the behavior index, and being less likely to be recommended by the coder. The perception that anti-fat attitudes are normal for doctors predicted ratings that the provider showed less interest, was less friendly, was less engaged, was less respectful, less interactive. Again, they were less likely to be recommended, and again, scored lower on the patient-centered behavior index. So shifting from communication to clinical decision-making, and I want to be cognizant of the time too. Quantitative evidence is scarce. Qualitative evidence points towards patients having their presenting complaint ignored and conversation focused on weight loss instead. Some of the quantitative evidence that is out there includes studies finding that a study finding that virtual people with larger bodies and breathing difficulties were less likely to receive asthma medication and more likely to receive weight loss advice. Some findings that people with obesity are more likely to receive opioid treatment rather than other kinds of treatment for chronic pain, and are less likely to be offered flu shots and other preventative measures. One more study of mine I'll go into. So this was called the DAD study, and I can't remember what DAD stands for anymore, but we're interested in, does parent body size or parent race influence care for pediatric type 1 diabetes? Insulin pump therapy with continuous glucose monitoring offers the best glycemic control, but can also be very complicated to manage for children. Parents have to deal with infusion site errors. The process is just less in control because it's happening automatically. And so there's a lot of uncertainty about when and under which conditions insulin pump therapy is the best option for children. So I designed a 2x2 vignette study, recruited 413 pediatric endocrinologists across the US, presented them with a patient case and an image of a woman with a larger or smaller body and a child, and the parent and child were both either white or Black. We emailed invitations to 1,070 AMA members who were pediatric endocrinologist specialists, and 413 replied and completed the task. The procedure was that participants read the vignette and saw the pictures, and then were able to ask any number of questions from a list of 50 questions arranged by 9 topics, and they would receive a response. The question categories fell under knowledge, storage, dosing, injection, testing, social factors, support, diet and exercise, and complications. And then they completed a questionnaire asking for their treatment decision, the reasons behind their decisions, and their beliefs and attitudes about the patient and mother. This was the summary of the vignette they read. It was a 10-year-old girl, follow-up visit to check on her diabetes. She has had type 1 since age 4. She's currently on a regimen of glargine-based insulin at bedtime and short-acting insulin 3 times a day. Her A1C is not controlled, 9.4%. Otherwise healthy, developmentally normal girl. No mention of diabetic ketoacidosis. Her mother wants to know what they can do to improve her blood glucose control, and the insurance was kept the same across all cases. So it just said the girl's insurance will cover 80% of the treatment costs. And then everybody was presented with one of these 4 images, and this was the kind of experimental manipulation, that there was a Black family and a white family. The mother was presented with a larger body or with a smaller body. And we use drawings to get around other differences that can arise when you use photographs. People look different in lots of different ways. There's different levels of attractiveness, different things that we associate with dress. I've seen studies where people have taken one picture and manipulated body size with a computer program. I think it kind of has an uncanny valley thing when that happens. They sort of look a little like aliens. And so I didn't want to do that. So we hired one of the in-house Mayo artists to draw these 4 pictures on a computer for us. So looking at I should have said, so the idea with having them ask questions was that one of the hypotheses we were interested in was, do disparities emerge because of the questions that providers ask? So they go down 2 different pathways, perhaps, of asking questions, and it leads them to very reasonable decisions that might be disparate between groups, but that those questions were informed by the implicit stereotypes that they might have about those groups. So that's why we did this sort of, you could ask as many questions as you want part of it. So adjusted for respondents' race, BMI, sex, income, and practice location, there were no significant difference by patient and parent race. However, the lower body weight parent was asked more overall questions, more knowledge questions, more storage questions, dosing questions, injecting questions, social factors questions, and complications questions. It's a very interesting finding. It's hard, it's a little, can be difficult to interpret. One interpretation is that when a provider might be more certain of what is going on, of what the cause for the poor glycemic control is, there's possibly less likely to question, to try to discover. And if there's a family, obesity is an issue in a family, it can seem more kind of cut and dry what the problem is, why glycemic control is an issue, either because of family behaviors around food, or possibly because of stereotypes around kind of capability and effort among people with obesity. For the clinical decision, we asked them to select their one insulin treatment recommendation for this patient. 25% picked a more intense basal bolus insulin, self-administered insulin regimen, glargine or detamir plus rapid-acting insulin. just over half people did pick the insulin with continuous subcutaneous insulin pump, and almost nobody said a less frequent or less intense insulin regimen, which is good news. Nobody said other, oddly enough, and 21% suggested switching to insulin pens instead of bottles and syringes to make it a little less cumbersome. The comparing people who made the continuous subcutaneous insulin pump decision to any other decision, people who saw the smaller body size mother, 59% of them went with the continuous insulin pump. People who saw the larger body size mother, 49% of them went with the continuous insulin glucose pump. Yeah, pump, insulin pump, not glucose pump. And that difference was just significant. So there was a significant, marginally significant, but significant difference where girls with poorly controlled diabetes in this vignette who had a mother with a larger body size was less likely to get this treatment that has better outcomes, but is also potentially more complicated to manage. So moving real quick into solutions, I'm running out of time, so I'm just going to kind of flow through this. I wanted to touch back on the changes longitudinal study, because we found the finding that role modeling was so important for weight bias. And I want to come back to this role modeling. It's also what we found in the contact study with the medical students in the simulation center. There's the idea in medical education of the hidden curriculum, that so much of what students learn comes from trying to emulate the people that are training them and be like them and learn what it means to be a doctor by acting like them. In the changes study, faculty role modeling of discrimination against higher weight patients predicted increased bias during medical school. That's what we saw. Faculty role modeling of discrimination against LGBT patients predicted increased bias during medical school. Faculty role modeling of discrimination against African American patients also predicted increased bias during medical school. It was very, very consistent independent variable in that study. Social consensus is powerful, right? Organizational norms are powerful. One solution and one thing that I think there's evidence to suggest that intervening with instructors, with the people who are providing the instruction, people who are mentors, and that students are trying to emulate is a positive target from some of this evidence. Zero tolerance for derogatory comments, taking a learning and growth orientation, making it okay for people to learn from mistakes, be called out on mistakes, to empower people to have that sort of upstander attitude where they're encouraged to call people out on mistakes, and that it's beneficial for everyone to examine decisions for bias and be honest about that. Some other recommendations: conducting organization-wide climate survey to understand assumptions and attitudes, and stigmatize group members' experiences of microaggression and feelings of belonging and safety. There's some other studies that I didn't get into about kind of the experience of medical students with obesity and some of the stress and mental health outcomes associated with that. And organization-wide settings to try to provide a shared set of understandings and expectations, to try to make a difference on a social level within an institution. Other strategies that may reduce the impact of bias and behavior. Perspective taking is one that on an individual level has been shown to strengthen empathy. Emotion regulation, especially among busy healthcare providers, people with a lot of cognitive load, emotion regulation can help you move that cognition from the implicit process to the explicit process and give it thought as opposed to relying on heuristics and stereotypes that are immediately available. Partnership building, or trying to find a common identity to force the perspective of being common in-group members has been shown to be effective in healthcare provider patient studies. Strategies that can protect patients from biased behaviors, asking them to affirm their values. Values affirmation is something of a almost magical intervention, it seems like, in these psychology conferences I go to. But people, when they have an opportunity to affirm their values, can deal with the threat of stigma a lot better and recover much more quickly. Helping patients have external attribution for failure, for having not lost weight, so they don't internalize that. Examining the clinical space for threatening cues, making sure that everybody fits and that everybody feels like they belong and are welcome there. And reducing the focus on weight as a diagnostic factor. It's most of the science out there, shows that nutrition and physical activity are important predictors of chronic disease, but once those are taken into consideration, one's actual BMI is a minimal effect. And so reduce focus on the scale, but increase the focus on healthy behaviors. I'm working right now with a group on trying to come up with a shared decision aid for discussing weight loss. And one of the things I'm really pushing for is that it be agnostic to the size of the patient, that it be something that we use with patients across the BMI spectrum, and it not be about weight loss, but be about improving health behaviors, and not even mention weight loss or bring that in. So a little bit of the current work. Just wanted to, this is just sort of like what I'm up to because I'm talking to the program that I trained in. I'm currently evaluating medical school obesity care curricula at Campbell University and also at Mayo Clinic. I've been fortunate, I get 2 hours a year with our medical students, one during the endocrinology block and one during the psychiatry block, to talk about these things. Doing some work on evaluating a virtual reality intervention to develop cognitive and emotional empathy for stigmatized others. That's a really interesting project. I'm working with an outside company owned by somebody that most of you should know or probably know, Michelle Van Ryn, my sort of longtime mentor. Started a company called Diversity Science, and we're developing e-learning modules on weight bias for healthcare providers. I'm currently conducting a community survey to understand how care access and care quality experiences changed for stigmatized groups, including people with obesity during COVID. In theory, COVID increased clinical stress, increased cognitive load, and so, in theory, that would have contributed to more reliance on heuristic stereotypes and lower quality care. And I'm also really excited about this. I'm working with a team of experts from around the world called the Weight Bias Work Group to develop some really much needed better measures to assess stigma across multiple settings. So that is my work in a nutshell. I want to acknowledge the collaborators on the studies that I presented here. It's a long list of people, a couple of whom are in the audience. I'm pretty sure I saw Mark Giesel there before I switched to presentation mode. But I work with some really wonderful people, including Michelle Van Ryn, Jack DeVideo, and Rebecca Poole on this work and other work related to bias. And so that is what I have. That's my email address. Anyone's welcome to contact me. And we have 4 minutes for questions.
Thank you so much, Sean. I'm sure I speak for the faculty on the call, but you pass again.
Oh, good. Okay.
I'm going to thank you formally now, and I know that that people may need to leave at 11. But can I ask you a second favor? Are you able to stay with us for an extra 10 minutes?
Oh yeah, I've got time for sure.
So we'll have 15 minutes for conversation, 10 minutes past the hour.
Okay.
I invite either questions or comments at this time. Sean is more than willing to speak about his work and answer any questions. What I suggest is you use the raised hand function. I want to invite those who made comments in the chat box to introduce yourself so we can just continue the conversation.
Well, while people are kind of forming questions or thinking about what they might ask, I do want to just kind of throw something out. So being at Mayo Clinic has a lot of pluses and a lot of minuses, right? It's a healthcare organization that is certainly patient care first, research second. And part of being in an organization like that is access to and exposure to students. Because of that, I do quite a bit of mentoring of people outside of Mayo Clinic, but we really don't have a pool of students to work with. And so right now there's 3 or 4 students that are using the changes data or the contact data as part of their theses or dissertations. And I just kind of want to just suggest, if anyone's interested in reaching out, the changes data is especially immense. I mean, we've probably gotten 50 publications from it, but at the same time, hardly touched a lot of that residency data. And so if people have interested touching base about using some of that data, I welcome that. I'd love to just chat about it.
Thank you. So the first question or comment will be from Mayan, who's from Washington, Department of Health.
Hi, thank you so much, Sean, for that talk. That was great. I'm here because Mandy Starr suggested I join.
Okay.
So say hello to Mandy, yes. So I'm an epidemiologist. I work at the Washington State Department of Health. I am a graduate of an epidemiology program at the University of Washington. And I'm also a member of the Council of State and Territorial Epidemiologists, which is the largest organization in the country for applied epidemiologists, right? And we are doing some work right now in a working group that I'm leading around weight stigma, fat stigma. We do not use the term obesity whatsoever. And the fact that it is perpetuated in the public health and medical environments, but especially in public health agencies. And it's an area that I think our world in public health needs to think about some more, how we talk about obesity, people with obesity, which I also think is a problematic phrase, but you also brought that up, which I'm grateful for. But I think it's very interesting that you're talking about primarily the clinical environment, which is where this comes up. But I'm curious how you plan to, or if you have thought about how the work you're doing also influences the way that we talk about health at a community level in the context of public health agencies.
Yeah, interesting question. I mean, I'd love to think, like you said, I'm focused, a lot of my focus is on clinical care. The community survey around COVID that that I mentioned just there at the end, I'm trying to think, I mean, part of it was access and care quality, but another big part of it was internalized stigma, behaviors sort of during COVID, and how people feel about themselves, how much they worry about weight gain or weight loss relative to other worries, that over the last couple of years. There's a lot of, I think, really interesting questions that I'd like to ask of that aren't really clinical care related. How people, especially just how much people worry about changes that have happened over the course of this kind of COVID nightmare. So I guess that's one example. I'd love to kind of chat about others because I feel like that's an unsatisfactory answer. I'd love to think about it more.
Would you mind if I asked you a question, Ryan? We love to hear from governmental public health folks. So what problems specifically are you seeing in your work environment and the work that you do, and or what solutions are you implementing?
I think that's a great question. So part of the problem is that in the culture of public health, we are so driven by the medicalization of a variety of factors that don't necessarily need to be medicalized. And, Sean mentioned that the literature around and the science and evidence around fatness and health is really quite weak. And in fact, it is stigma that can explain so much of those poor health outcomes that historically literature has tied directly to fatness, because you have a really important confounder of stigma. So ultimately, what we are trying to do, at least in our working group, is start to untangle a bit the way that the stigma and preconceptions around fatness are infused in everything we do, from the programs and the policies and the language at public health agencies. Think about weight loss campaigns for kids, or anti-obesity projects or healthy eating, active living. Is that a better phrase or is it not? So there's a lot of ways that our programs at public health departments continue to perpetuate these sort of misconceptions or, false narratives around weight and fatness and health. And so what we're trying to do about it right now is we're developing within a working group a toolkit for epidemiologists that will help them explore what this kind of stigma looks like in public health, tools for how to bring that conversation to the leadership within their organizations, also some measurement alternatives for trying to get at the same underlying issues. And then we are going to use this sort of model template to actually create sort of a stigma toolkit development process and support our epidemiologists around the country in looking at other types of stigma, some of which Sean mentioned, and how to develop tools to support EPIs more broadly and really public health agencies more broadly.
Fascinating. Thank you so much.
That's really great to hear. That's fantastic.
Great. We'll keep talking.
Really exciting.
Laura.
Yeah, and of course, on a policy level, people with higher weight people are not a protected class, right? And so that's outside of Michigan, at least. And so that's one immediate kind of policy need is to it's illegal in a workplace to discriminate against people of size.
Laura Hooper.
Hi, Dr. Phelan. So thank you so much for this wonderful presentation. I'm a PhD student here at the U and actually study weight stigma. My previous experience was as a pediatric dietitian, where I worked in both obesity care and also eating disorders care and trained medical students and pediatrics residents. And so one of the things that I've started to do recently is give lectures to interdisciplinary clinical audiences and have conversations with med students and residents. And I'm very curious to hear your experience in terms of talking with, like, presenting this evidence to your med students at Mayo Clinic, and what basically, I guess my question is just this finding that you have found around like the decline in favorability scores during medical school, like the role modeling very much resonates with my experience in the clinical setting, and very much resonates with what like residents have shared with me more recently in terms of what their attendings are doing really influences what they're able to do. Or what they feel pressured to do in terms of talking to patients about their obesity, but yet not necessarily feeling equipped or trained to have the proper skills to have those conversations in a compassionate way. And so I'm just kind of curious to hear a little bit more about your thoughts about intervening on the faculty level versus on the med student or resident level.
Yeah, I love talking with medical students and presenting to medical students because it is, I get a lot of emails afterwards saying, I'd love to talk with you more about this. That was a great, talk. A lot of times, I hadn't thought about that, but I think it's really important. I mean, obviously people, they might not speak up if they think I'm, if what I'm talking about just isn't true, or if they're students, they don't feel comfortable speaking up. But among our students, it's a very heartening experience to talk with them, because a lot of people are along for the ride and in agreement and engaged, and really kind of aware of these issues, maybe not related to obesity, but they've been exposed to some size, fat acceptance, some size pride, right? And so it's not a foreign topic to them. I have a more difficult time with practicing physicians, and it depends a lot on the specialty and just the physician. There's a lot of people who I publish with, and they're see eye to eye, and they're fantastic. Mark is here; he's one of them. Manpreet Mundi is an endocrinologist I publish with. He's another one. At the same time, I've given presentations and had someone raise their hand and say, you know, every piece of evidence you just provided, I could provide one saying the exact opposite, and you're just cherry picking and making stuff up. And that's out there. It's part of the, you know, we sort of trained and grew up with this acceptance of the kind of model of obesity that we all have. And it's just, it's, you know, it's like suggesting, I don't know of a good comparison, but it's like suggesting something you've always known to be fact might not be fact. And so it's threatening, I think, to a lot of people who practice medicine based on the assumption that they need to address obesity at every time. They need to potentially use stigma as a tool and help make patients feel bad about it so that they're motivated to change. And yeah, that can be, there's still a lot of work to, in some ways it's you know, I do work around race bias as well. And for the most part with physicians and race bias, everybody's on board. They might not behave, you know, their behavior might contribute to disparities, right? But very few people stand up and say, you know, I think what you're doing is nonsense. With obesity, you do get that. And so it reminds me how young the science is and how much more convincing has to be done to kind of change people's minds about how to think about it.
Laura, what year are you in the program?
Well, I'm actually a nutrition student, but my minor is in Epi, and then I study with Dr. Diane Newmark-Steiner and the Project EAT team. So that's
fantastic. Then tell us, can you tell us a little bit about your own work then?
Oh, sure. So I am looking in using the Project EAT 2010-2018 cohort to investigate how the experiences of weight stigma, including weight teasing, affect health outcomes in young people. So looking cross-sectionally at adolescents, cross-sectionally at young adulthood, and then longitudinally. So I'm looking at outcomes. I'm looking at BMI. I'm also looking at nutrition and activity behaviors, and also disordered eating behaviors as my outcomes. And then I also am a tracked TL1 scholar here at the U. And so it's a translational science fellowship through the CTSI. And so through that work, I'm starting to generate hypotheses. And then, as I was mentioning, do some dissemination with clinical audiences in particular, because this, as Dr. Phelan is highlighting, like this body of evidence is growing and is so strong now that weight stigma is not helpful to the health of and well-being of young people and is a threat. And so if healthcare settings and healthcare providers are sources of that stigma, then my shift and my interest going forward is trying to affect change in the healthcare settings, and very similar to what Dr. Phelan you've mentioned. And so we should chat more for sure.
Yeah, no, we should.
Wonderful. Sean, we have our last question coming from Diane Newmark-Steiner, of course, our division chair, and it relates to Laura's work and all the up and coming people like Laura. So how do we keep them funded? Do you have any hints as to how to successfully gain research funds to further your work?
Yeah, you know, it's a challenge, but almost, you know, I feel like all sort of social sciences can always be a challenge. One thing, there's sort of two strategies that I think have helped me. I don't know for sure, but I think have helped me is framing, and it's not in any way, you know, like dishonest. It really is an interest, but framing this as weight stigma as a barrier to effective weight loss intervention. You know, stigma causes or leads providers to communicate in ways that don't lead to positive outcomes, right? And so studying stigma as a way to improve those processes could actually help with weight loss outcomes. And that's something that is really, really speaks to funders, right? Weight loss outcomes. So that's one strategy. That's entirely how I framed my KOR. It was, it was all about best practices for helping patients lose weight.
So in addition to NIH, which funders are you focused on for this work?
NIH, although haven't had luck in the last couple of years, right now I've got some funding from HRSA to develop the e-learning related to stigma. I have some part of a larger study. It's a PCORI grant to look at a communication aid, and it's actually around a disability, but it sort of touches on communication about behavior change in general. What else? Hopefully we'll be getting some foundation funding here to evaluate some of the e-learning work that I've done with Dr. Van Rijn. Yeah, that's what I've got right now, currently.
So thank you so much. We've seen through the chat many, many times how appreciative people are of this work. We are appreciative of your time today and even going over. So thank you again, Sean. And people want to be in touch with you. We'll see you soon, Sean.
Yeah, please, reach out via email. I'd love to hear from people. Can the chat be saved? Because I think there's been questions that I haven't seen.
Mostly are comments. I passed on any questions, but we will ask Jeff to save the chat for us.
Okay, thanks a lot. Thank you very much, everyone.
Thank you so much. Such a pleasure, really.
Thank you, Diane. Nice to see you.
Great to see you doing this work. Bye.
Bye.
Bye. Bye, everyone. See you next week.